Welcome to Hello Health, a partnership with the Ochsner Health System and Humana to bring Ochsner's Hello Health weekly education and information series to you. Our topic this week, the beat of the heart and devices that can help us get back in rhythm and sometimes even save lives. Our guest is cardiac electrophysiologist Dan Morin. First, some background. Dr. Morin received his medical degree from the University of Massachusetts Medical School. He got his Master of Public Health at Harvard. He completed his internship and residency at Tufts New England Medical Center in Boston. And he did 2 fellowships in cardiovascular disease and cardiac electrophysiology at the New York Presbyterian Hospital's Weill Cornell Medical Center. He is board certified in cardiology and clinical cardiac electrophysiology, and it is our pleasure to welcome back to the program cardiac electrophysiologist Dan Morin to Hello Health. Good to have you back here.
Good to be here. Thanks so much.
So let's talk about the pacemaker, first of all, and how common they are and how does it work?
Well, pacemakers are very, very common, of course. That's part of why I have a job and why there are 6 electrophysiologists at Ochsner.
Wow.
So we have a very large population of patients who have devices and other heart rhythm issues that may not require devices as well. So your question was about pacemakers, and a pacemaker's only job is to make the heart go fast enough. And people need pacemakers when their own heart doesn't go fast enough by itself.
You're going to look at that as a physician and take all the input and medical data, but sometimes a patient himself or herself will know that there's corrective action needed. Here's an Ochsner patient story.
That night on the way out to the hospital, I remember looking at my wife thinking, I'm going to die tonight. And I looked at her, and we had just buried her mother 10 days before, and I said, I can't do this to her. I started running in college and been running ever since. And then I said, there's this thing called a triathlon. All we need to do is learn how to ride a bike, and we can do this. February, March of last year, and we were training just like we always do, and I'd go out for a run, and something wasn't right. I'd get out of the pool and go sit over in the bleachers, and and that's just not me. Early January, Monday night, and I was at dinner, and all of a sudden I just went down. And I recall thinking there's about a 50-50 chance I'm not going to make it through the night.
Billy here has a very strong muscle of his heart. Sometimes, though, without help, Billy's heart goes too slowly. That's where Billy's pacemaker, which he's had for some time, comes in. Billy's pacemaker, which is the little device that's implanted in his chest wall, enables him to do all of the exercise that he likes to do.
We had the problem, they put the pacemaker in. It probably made me just want to prove to myself that I could continue to do it and push even harder. Life is short, live it hard, live it well, and love everybody around you.
You could see the emotion in his eyes and voice, and I could see it with watching you listen to it.
It's so wonderful to help people.
So where is the pacemaker placed inside the body, and what does it look like from the outside?
So that's a great question. So I've got one here to show you. We can look at these first. This is a pacemaker with its pacemaker lead. We've seen a picture already, sort of a cartoon of it. This is one model of pacemaker. It's primarily battery here in the casing. Well, it's a metal casing, and then on top of it there's a plastic resin sort of header, which has a couple holes in it, and into those holes goes the pacemaker wire. The pacemaker wire goes into the hole and then is able to make its way down into the heart that we saw on that picture. On the picture that we have up on the screen presently, you see on the left a picture of what the device might look like in a very thin woman. You can see the outline of the device inside her left anterior chest or left front chest. And then on the right side is a chest x-ray that shows what it looks like when it's implanted, and we take a look at it with the x-ray.
What's the difference between a pacemaker and a defibrillator, and when is a defibrillator a better option?
Well, as I mentioned, the only job of a pacemaker is to take care of people whose heartbeats go too slowly by themselves. If the heartbeat is going fast enough, then a pacemaker's job is just to sit there and watch for it to go slower. In contrast, a defibrillator is able to do that. Most defibrillators are able to also act as a pacemaker, but in addition, they can take care of bad, dangerous, abnormally fast heart rhythms that could be deadly.
Okay. So if a defibrillator can be a pacemaker as well, act as a pacemaker as well, why wouldn't you just always use defibrillators?
They're structurally different. A defibrillator is structurally bigger. It's connected to a different type of wire, which we'll talk about. That would potentially be more challenging to extract, for example, later on if that is required.
How common is it that someone will need a defibrillator at some point in their life?
Unfortunately, it's very common. A defibrillator's job, as I mentioned, is to prevent or treat people who are having a sudden cardiac arrest event where the heart goes abnormally too fast. And I have to say that sudden cardiac arrest is extremely common. We see here a graphic that we can show of the leading causes of death in the United States. And up there are some things that you think about causing lots of death: diabetes, accidents, stroke, things along those lines. And if you look down at the red line, you can see that sudden cardiac arrest is second only to all cancers combined in terms of number of lives lost in America.
How does a doctor know if a patient is at a higher risk of developing sudden cardiac arrest?
Well, there are a number of ways to know. There are certain inherited syndromes, so that we know, for example, if a patient's close family member has died of a sudden cardiac arrest, we know to screen other patients that they're related to for those same diseases, which are usually genetically passed down from parents to children. But also, at other times, sort of run-of-the-mill problems, sometimes unfortunately run-of-the-mill problems, things along the lines of heart attacks and other types of heart failure causing diseases can cause the heart squeezing function or ejection fraction to go down over time.
And you brought along some videos side by side that you're going to share with us. What are we seeing on the left side, doctor, and what are we seeing on the right?
Sure. So on the left side, so these are MRI movies, so to speak, of the inside of the heart, of the inside of the chest. And you can see that when the heart is moving, you can see that under normal conditions, which we see on the left side of the screen, we see that the normal ejection fraction or squeezing function of the left ventricle, which is the rightmost chamber in this image, is very strong and powerful, squeezing about 55 to 65% out with each beat. In contrast, when we see the movie on the right side, a patient with a low ejection fraction, that is less than 40%, and here it's very, very weak at only about 10%, that is usually the doctor's main way that we show that we know who is at highest risk for sudden cardiac arrest, and those are the patients that receive a prophylactic defibrillator.
How will a patient benefit from a defibrillator?
A patient would benefit from a defibrillator because the defibrillator protects them from sudden cardiac arrest. Just as the pacemaker is always watching to make sure that the heart is not going too slowly, the defibrillator is also watching to make sure that it doesn't go abnormally fast, which can cause people to pass out. And if that bad rhythm lasts long enough, it usually causes people to die. Now we see here on the chest x-ray that we're showing a defibrillator which only has one lead attached to it, which the lead is the wire. And that goes in through the blood vessel and then down into the heart. And it has on that wire two thick spots that are able to deliver a large shock that goes from those thick spots, or the coils, to the defibrillator itself. And you can see on the EKG in the bottom, we have a ventricular fibrillation rhythm happening on the left side. That is a deadly rhythm that, if left untreated, would result in the patient dying. However, the defibrillator here is able to deliver a life-saving shock and return the patient to the normal rhythm that we see over on the right.
What is it? Does it feel like a shock to the patient?
Well, it depends on what kind of person you are. So oftentimes when patients require a shock, they've already lost consciousness. And so oftentimes what happens is the patient is doing whatever they're doing during the day. Then they suddenly find themselves on the floor and they say, "What just happened?" Other times, patients don't lose consciousness before receiving a shock. And it depends, again, what you're doing. If you're a sportsman, you say you got hit by a baseball bat in your chest. If you're a trucker, you say you got run over by a Mag truck. If you're a farmer, you say a mule kicked you. It's strong.
That's the shock itself, or that's the heart going out of rhythm before it's shocked back into rhythm?
That's actually all of your other muscles that are contracting all at the same time, creating the sensation that everything is being stimulated, and that's why it's so powerful.
Is this data being sent back to the hospital? How is the data monitored, or is it?
Well, so it is. With modern devices, almost all of the devices, for these, when a patient receives a device, they also receive a box that they're able to put in their home next to their bed. And periodically, that device is able to talk to the bedside box via sort of Bluetooth to check the function of the pacemaker or defibrillator and periodically send it back to us at Ochsner as well.
We've been talking about the pacemaker and the defibrillator. It might be nice for our viewers to see a side-by-side comparison of the two devices. So walk us through this, if you will.
Sure. So we have a cartoon version of it. On the left side, we have a pacemaker. And the pacemaker, you can see, is usually implanted in the left chest. Sometimes we put them in the right chest or in other places, but the left chest is 98% of the time. It has wires that go into the blood vessels, and the blood vessels act as highways through which we place the wires down into the heart. Oftentimes these wires actually screw into the muscle on the inside of the heart. In contrast, the defibrillator, or ICD, implantable cardioverter defibrillator, is seen on the right side. This also is connected to two wires. It's larger than a pacemaker by and large because these things need capacitors that are able to make larger shocks. In addition, the wires are different. The wires, in addition to being able to pace, also have to be able to deliver a life-saving shock, and so they have a coil in the bottom of that lead. And I have that to show as well, if you'd like.
Yeah, let's take a look, just side by side, the two of them there.
All right. So we've got the pacemaker closer to you, closer to my fingertips, and the defibrillator, which is a little bit bigger, closer to me, closer to my palm.
Very good. Our guest this week is heart rhythm doctor, Dr. Daniel Morin, and we're talking about the beat of the heart and getting it back in rhythm, and when the heart has other ideas. And there's other benefits, right, to a pacemaker. Synchronization, for example, could be helpful.
Yes. So in addition to the speed of the heart, some of these devices can also work to make the heart beat better on a beat-to-beat basis. For some people, the two sides of the lower chamber of the heart, the left ventricle, are weak. And that results in a lower ejection fraction and therefore results in a lower ability of the heart to pump blood around the body. In addition, though, there can be timing differences. If you consider that the heart is a pump, you want both sides of that pump to be working at the same time. But for some people, their right side comes in first and then their left side comes in later. If we only have a wire on the right side, we're not doing anything for the left. But if I put another wire on the left side of the heart, now I can resynchronize that left ventricle, making it squeeze more efficiently and helping the patient to feel better.
What kind of care is required for someone with a pacemaker or a defibrillator?
So for a pacemaker, we usually see those patients about once a year in clinic. But in addition, we use those monitors that we discussed to telephonically or over telephone lines monitor how well their device is working and how well the lead is working, how much longer they have on their battery life, for example.
How long do they last? Are they meant to last a lifetime? And how are they powered? And if it's batteries, how often do you have to change them?
So it's a good question. So most of the can is made up of battery. About 75% of the actual box is made of a battery. And pacemakers and defibrillators nowadays are lasting anywhere between 6 and 12 years, I would say, on average, and it depends on how often you have to use it. If your pacemaker is very seldom using energy to power your heart, well then it's not wearing down the battery. Just as if you don't drive your radio-controlled car very frequently, it can sit on the shelf for a longer period of time. In contrast, if you need multiple shocks from your defibrillator, that wears down the battery at the rate of about 1 month of battery life per shock.
We're going to talk about removing these devices in just a moment, but I'm going to jump ahead for just a second. Are there times that we put the devices in thinking that a patient really needs them, and then based on data, I've had one of these for 5 years now and it's never been used. Is that a risk worth taking? Or the question is, and the problem is, you never know when you're going to need it.
You never know when you're going to need it. If I knew when people were going to suffer sudden cardiac arrest, I would go to their house on that day and enjoy a nice dinner or something and bring my defibrillator, my external defibrillator with them so that I would be ready to save them. But we really don't know, and that's why it's called sudden cardiac arrest, because it happens oftentimes without warning, and if not treated immediately, it usually results in the patient not surviving.
So when we're watching a medical show on TV and we see the paddles come out, just because I saw you do that, it's the same thing except internal,
It's
right?
exactly the same thing.
Okay. Do you ever remove the device? When you do remove the devices, why would you remove them?
Sometimes we do have to remove these devices. This is something that Ochsner is a major referral center for. So we get sent lots of patients who require removal of their devices because you can't do it in any facility. A major reason for removal of these devices is that sometimes they malfunction. Sometimes there are fractures of the leads. Sometimes the insulation on the outside gets worn away or eroded. And so the wires don't work. And you may need to remove those wires in order to be able to put in the new ones. A major reason for removal of these devices, the biggest reason, is infection, unfortunately. And if a device like this is infected, you simply can't clear the infection without removing the entire device, including the leads.
The doctors brought along a series of videos to show us what the device looks like inside and exactly how it's removed. So let's walk us through these, if you would.
Right, so first the still picture shows one of the reasons that extracting a device is a big deal. And that is that once these leads or wires have been in place for a long period of time, your body sort of grabs onto it with fibrous scar material. And that makes it such that it's not the case that I can just unscrew this wire and pluck it on out. Rather, I need to deal with these fibrous adhesions that are on the inside. Here, this is a cutaway view of the inside of one of these blood vessels through which the wires are going. And you can see that on the wires, there is a mock-up of the fibrous adhesions. You can see in this picture we're using a laser sheath in order to cut away those fibrous adhesions in order to be able to remove the leads.
And what do we see in the videos?
The first videos that we have, this is a patient who has one of our cardiac resynchronization devices that we talked about. You can see that there's 3 leads. One in the top left of the screen is in the right atrium or top chamber of the heart. One on the bottom is the defibrillator lead that's in the right ventricle, the right bottom chamber. And then the third wire, which is sort of northeast in this picture, is the cardiac resynchronization lead. This patient was infected and therefore needed all of his device removed.
Okay. In the second video?
The next video shows a video of the laser sheath going down over the wire. Now this laser sheath is plastic with fiber optics on the inside, and it actually shoots a laser out from the end of that sheath, which is like a tube, cutting away the fibrous adhesions that are preventing the lead from being removed.
And in the third in the series?
In the third in the series, we're getting our laser sheath all the way down, or at least in this video, very close to all the way down to the tip of the lead, thereby allowing the lead to be extracted from the patient safely.
In these next two videos, we're actually going to see the extraction take place. Doctor?
So this is actually using a different type of technology called a snare. In this case, we've got this snare that's coming up from the patient's leg through the blood vessel all the way up to the chest. And we have a number of different snares, and you'll see this snare in a moment grab on to this lead. And once we get a hold of it, then we're able to pull this cardiac resynchronization lead down into the sheath, and you'll see that with the next video where the wire actually gets pulled straight out, pulling a heart wire out through the leg.
You mentioned the optics, so you're able to see what you're doing inside here.
Well, we can see this is the exact video that I see during the procedure. And in addition, this sort of large black thing that's coming down from the top of the screen is a transesophageal echocardiogram. So it's a picture using ultrasound of the heart that we have an echo doctor always watching for any complications that may be happening during the extraction procedure.
So the lead comes out, and we're actually going to show you what that lead looks like. We do want to warn you if you're a little squeamish, but this is a medical program, so we are going to show it to you, but just close your eyes for a moment if you are a little squeamish. What does the lead look like, doctor, when it comes out? Show us.
Well, you can see this is a picture of me on the left side after I have removed one of these wires. And you can see not only on the lead that I'm holding up in this picture, but also in the close-ups of the other leads, that there's oftentimes a large amount of fibrous or infected material that's on there. There's clot oftentimes as well.
I was joking and said, does a patient ever ask to bring it home? And you said sometimes they do, but oftentimes they're sent to a lab, right, for checking?
Right, we send it to the lab because remember, one of the major reasons to extract these devices is infection. And it helps our infectious disease doctors very much if we know what bacterium was causing the infection. The best way to do that is to send it to the lab.
How would a patient know there's an infection there?
The same way you know that you've got the flu oftentimes. You've got the fever, you're feeling terrible. Oftentimes these patients will actually present with a pus-filled pocket of their device, so it's physically painful and red and ugly looking.
How often do these devices have to be removed, or do you have patients who have them for the rest of their life and don't have to be removed at all?
We have the whole gambit. So we have some patients who unfortunately get infected right around the time of implantation. We have patients who live 50 years with a device and don't need anything done to them. That's rare, of course, and then everything in between.
If we're talking about anything at Ochsner, we're talking about a team. So walk us through the operating room. Mm-hmm. We have a picture of it actually to share with people. Who's in the room with you and who's doing what?
All right, so this will be a picture of our operating room, which we call the lab, because we're not oftentimes doing surgery where we're making a large incision. We're doing all of this through small incisions. This is Lab 1 at Ochsner Medical Center. We've revamped our labs about 8 years ago, I would say, and we've got just fantastic equipment. You see the table where the patient goes in the middle. We've got an X-ray camera that's right over the patient, and we've got the television screens. We don't watch the Saints on those screens. We watch the videos that we've just been showing. People in the lab include me, the operator, my assistant, who's usually either a cardiology fellow or maybe one of the junior attending physicians. We have technicians whose job is to make sure that all of the equipment is working properly. We have nurses who are giving medicines. We have for an extraction procedure, for example, we have an anesthesiologist who's taking care of the patient's breathing. And then we always have on immediate backup a cardiothoracic surgeon who's there in case there's a complication.
If all goes well, how long does it take to put one in, and how long does it take to take one out?
To put in a standard pacemaker or defibrillator takes between 45 minutes and an hour with 1 or 2 leads. A cardiac resynchronization device, because it has the third lead, can take a longer period of time, maybe an hour and a half to 2.5 hours. To take out a device can vary tremendously. I have taken up to 7.5 hours to remove 2 systems, actually, on both sides of a patient's body.
What happens to a patient after extraction?
Well, after the extraction, certainly we monitor them at least overnight in the hospital, usually in our short stay unit, if patients don't require their device. If patients have a pacemaker need, then of course when we take out their pacemaker, their heart won't go without a pacemaker. And so we can show the picture that I've provided with a pacemaker stuck to a patient's neck, connected to a lead that then goes in through the neck and down into the heart. We will keep that patient, who is pacemaker dependent, in the intensive care unit for a number of weeks, for example, while their infection is clearing.
Okay. And then finally, any other options for defibrillators that have a lower risk or are less dangerous to remove?
There is another option, and that has come out maybe in the past 4 or 5 years or so. This is a fully subcutaneous defibrillator. The weak point of typical defibrillators and pacemakers is the wires. As I mentioned before, those can fracture sometimes, or the coating on it can erode away, causing dysfunction of the leads. Or any device can be infected as well. We see here on our screen a picture of the subcutaneous defibrillator. And the difference here is that this is connected to a wire that doesn't go into the bloodstream at all. It doesn't touch the heart, but it's still able to produce a defibrillator shock. You can see on the picture that the wire is actually on the outside of the rib cage, not entering into the bloodstream at all. And on the X-ray on the right is what it looks like on a chest X-ray. I actually have one of those defibrillators with me as well.
Very good. Doctor, thank you so much. Thank the doctor for the education and information he's provided tonight and for his work as part of the team at Ochsner. Thanks for being here.
Thank you.
Yeah. Well, to make an appointment with any Ochsner physician, including this week's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at the number you see on your screen, or send us an email. Here's our address, hellohealth@ochsner.org. As a reminder, you can re-watch this week's presentation and many of our other Hello Health programs on Ochsner's website at ochsner.org. Just type Hello Health in the search box. Our thanks again to this week's guest. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of this program, Hello Health. We'll see you next time.